starting Tube. And my very first guest today is a friend of mine, Maggie, Advocate for Nurses Maggie. You may know her from TikTok. That's how we met and realized we were, soul sisters in the fight for nurse advocacy. And so here we're going to be talking about how the convergence, of nurse advocacy and patient advocacy works. I'm a private patient advocate now. That's what I do professionally. I was a professional nurse advocate and also a nurse. I still pretty much do both, but my primary business is patient advocacy. And for me, from my view, and I know Maggie, probably will agree, the two are so interconnected. When we advocate for nurses, we are advocating for patients. They are inseparable. And when we don't advocate for nurses and healthcare workers, patients will suffer. So let's get started. So Maggie, welcome. And you want to just introduce yourself to everybody, let them know how to reach you?
Yeah, absolutely. Absolutely. Again, thank you for having me. And huge advocate for nurses. And that is my handle everywhere. Advocates for nurses. I don't get crazy with it. TikTok, Instagram, Facebook. So, like Adrian was saying, I do believe that patient advocacy and nurse advocacy do go hand in hand. So as a prior investigator for a board of nursing, someone who does nurse advocacy and helps nurses and their legal team when they're under investigation, I do believe, and I'm a solid believer in, when you're advocating for the patient, you are protecting your professional license.
Absolutely right. I mean, this is something that unbelievably is still not part of the curriculum of nursing school. How to protect your license, how to understand the laws that regulate your practice, right, in your state. You and I have spoke a little bit even about, and we won't really get into it in this episode, maybe down the line, but just how compact licenses work. What are you beholden to, right? And how many people actually are going to look at every state that they have a compact in, or even their own home state. So yeah, this is something that is a big issue, understanding your scope of practice. What is your Nurse Practice Act? What is it if you're an LPN, LVN, if you're in California, or an RN or an advanced practice nurse? And how is it defined in every state? Advanced practice nurses are defined differently in each state. So nothing's uniform about nursing, right?
No. And you hit that nail on the head. I do encourage nurses to go to the National Council for State Boards of Nursing, and you can get your Nurse Practice Act or the rules and regulations that govern your license right from there. There's a simple map. You hover over it, you click on your state, and it will take you to where your rules and your regulations live. Because just like you talked about, not every state has a board of nursing in the structure that you may think of it as. It could be under Health and Human Services. You could fall under the governor where it falls under occupational law, but you can still look that up, again, going to the National Council for State Boards of Nursing, or like some of us know, thank you, the NCBSN. And then you can go right on there and hover right over your state and look up things like unprofessional conduct, standards of care, and grounds for discipline. When I tell nurses, like on TikTok, it's a 10-minute, 15-minute read. That is what's going to dictate your practice in your state. So I would start there for sure. So great point. Absolutely, sister.
Right.
You're on mute.
All right, thanks. All right. I'm trying to pull up that website right now so I can put that up on the screen. Yeah. So, as you guys are watching, whoever's watching, make sure that you guys subscribe to my channel. Make sure you go over to Maggie's channel, follow her, subscribe. I'm going to put this website up because that is the NCSBN is a good resource to start with. If you don't know where to start at all, go there. Let me copy this. My computer.
Yeah, and it's a great resource for other things as well. I oftentimes tell nurses, just go there and start even looking at, like, what does alternative discipline mean? What would it mean if I was under investigation by a board of nursing? They have it there in videos. You can look at the transcripts. The videos are free to every single nurse. Even if you just know what that process looks like, the more education that you have and you understand, the less likely that you are to stand in front of a board of nursing or one of these entities. So yes, please. I do love this resource. It has lots of great information.
Yeah, they do have a great, website, lots of resources. That is really the place to start. So again, this is, and correct me if I'm wrong, this is an organization made up of representatives from all the state boards of nursing. That's who they are.
I do believe, I'm no expert on this, but yes, and they get input from all these regulatory boards. They are hooked up with NurseAdrianeRN, NURSYS. So that is the reporting body where most nurses know it to be, where we can go and look up your name. There are only, I do believe, 2 states that don't work with NurseAdrianeRN right now. I believe Michigan and California, but I do believe those are coming on board, just like compact states are still coming on board.
Gotcha. And this is very important that folks understand, nurses understand specifically, the regulations for your license are there to protect the public. There is a lot, and this is one of the most important things for everybody, every nurse to understand, anybody with a license to understand your rules of your licensure, your scope of practice, your practice act, whatever it might be, is to protect the public. It's not to protect you, right? You don't have anybody protecting you unless if you're an employee, you have some protections. That depends on each state, as far as, whether you have whistleblower rights or what have you. So it's really important. So I want to read you the mission of the NCSBN.
Yes!
NCSBN empowers and supports nursing regulators in their mandate to protect the public. These licensing boards are to protect the public, right? That's why they have standards. That's why we had this, there was such an uproar among so many of us about the fake nurses, and that we are very, vociferous about prosecuting them and finding them and removing them from patient care. So this is leading regulatory excellence worldwide. Right, it's 11 members, and they have their strategic plan, everything there. They've got all kinds of resources, communications library, brochures. So definitely check it out. But make sure you just understand your license. It's to protect the public. There's no board that says we're going to protect you, the patient. Now, some would argue that there are other licensing boards for other medical professionals that act in a more protective manner than nursing boards do. I would tend to agree. I would tend to agree. The AMA,
I would too.
And their state chapters are very protective to their members. And those are, some of those are nonprofits, but also the licensing boards themselves. So we said we were going to talk about common questions. So one of the things I asked Maggie as we were warming up for this is, what are some questions you get all the time? Let's just talk about the easy stuff, the low-hanging fruit, because these are the questions that people have over and over. And I mean, I've been doing nurse advocacy as a union organizer, community organizer, or as a nurse myself for well over 35 years, quite a long time, probably longer. So one of the questions that you had, and I get these same questions for like decades. So should I have medical malpractice? What do you say to folks, nurses who say, well, doesn't my job protect me? Isn't my boss or my company? They told us not to get that because that'll make us a target. So what do you say to all that?
I would have to disagree. And I do hold my own insurance. Because think about this, I've heard from an attorney that represents nurses, so an administrative lawyer, from her lips to my ears, a nurse is 98% more likely to stand in front of a board of nursing than in civil litigation. Because with the liability or the medical malpractice insurance, that's just going to cover you for a civil lawyer or administrative lawyer. So do you have thousands of dollars to write a check to this attorney? No, you don't. And now you get terminated from that organization. So who's representing you? And again, can you write a check for thousands of dollars to retain this lawyer? So if nothing else, it will afford you an attorney for administrative case. So, and then just think about this. If you are working for an organization and that patient has a bad outcome, Let's say that you were the primary caretaker for that patient and that patient died. It was a sentinel event. Now you, the physician, the hospital are named in this. The hospital is going to be defending what's their best interest here. And it comes down to something maybe that you did. Who do you think that they're going to protect? And I don't know this, but I mean, it's something you should really think about. Who are they trying to protect? So, and I always tell nurses, who's going to know that you have this insurance? Who are you going to tell? I mean, you're going to know it, but no one else is. And it is affordable. It's roughly about $10 a month. So my thing in this is that you're less likely to be named in a civil case and use it for civil litigation. You're more likely to have to use it for a board of nursing case. So I say yes. And then if you're a nurse practitioner, if you're a licensed independent practitioner, you're a CRNA, you're a nurse practitioner, holy cow, why would you not have it? I have heard nurse practitioners say that they don't have it, and I don't understand why, especially in a state where you have full authority to practice and you don't have malpractice insurance. I'm struggling with that. It just seems like a poor choice to make.
It really doesn't make sense. It's really cheap. I mean, depending on if you're an advanced practice,
Sure. Yes.
Of course, then, that's going to be different. Yes. But it's it's $120
a year.
Yeah. I'm making another banner here. So if you don't have malpractice insurance, I mean, NSO is the big player in the marketplace. Yeah. Some people say, well, should I just get a lawyer retainer kind of membership? I've seen that with a few law firms. I'm not that familiar with these law firms and how that works. NSO, I know, does great education programs also. You get free CEs. They're very, they have a lot of good resources. So really, honestly, for, $125 or whatever it might be, it's worth it.
I tell nurses, call your own insurance company. Geico has liability insurance for medical providers. Who would have known that? Mercer has it. So I tell people, just start with your own insurance company. They have a vested interest to take more of your money. Just call them and just say, hey, do you offer this service? And if you don't, maybe do you work with another company that does? You may even get a discount because you're a member here, and then they can offer you. You just tell them what you do. For me, I was testifying. I testify. I was at the bedside. So it's just like homeowners, car insurance. You just tell them what you do, what your discipline is, and they just tailor it to what your needs are. And it is, like you said, if you're a CRNA or a nurse practitioner, of course it's going to be more than me, the bedside nurse that's showing up, where my liability is a lot less than yours.
And then and remember, this is state by state. So contact your insurance company. Also, if you're moving out of state or working out of state, you want to let your insurance company know. You want to check what your coverage is. I don't know. Do travel nurses have special insurance? Is it different for travel nurses? Maggie, do you know anything about that?
I do believe it is a different coverage because, again, you're letting them know that you are a travel nurse. So organizations, like you said, NNU is actually who I do have. And so you would just tell them, hey, so I'm traveling. So what does your coverage will probably change because you're a temporary worker and your liability is different because, for obvious reasons, I believe, you're temporary help.
Gotcha. Okay. All right. I think that covers that. Get the insurance, right? That's it. All right. So now we're going to go. Okay. I'm playing around here with these. All right. Now we got just using that as a solid banner.
Yeah.
Okay. So how to refuse an unsafe patient assignment. This is one that I have gotten for years. When I was a union rep, union organizer, I would have nurses, CNAs, respiratory therapists, LVNs, LPNs, call me. Hey, we have a really unsafe assignment, or it would be something crazy oftentimes. But it could be that this is the new normal, right? And we are seeing this as a new normal. And when a nurse and for a patient, I want to say on the other side of that, you may have a delay and become aware that there is some dispute about whether a nurse is going to take over care. And that may become just known to you because wherever the conversation takes place. And so, that we never want that to happen, but please understand that this is because somebody is standing up for you. Because when we have unsafe assignments, too many patients, the acuity, the people are too sick, the patients are too sick and too many of them, they need multiple levels of care. and there may not even be any aides anymore. You don't have secretaries, you don't have anybody answering the phone. I mean, there's so much that's happening. So let's talk about how to refuse an unsafe patient assignment. And you can talk about your state, where you're at. What are some other tactics people can use that may not be, that are somewhere else in another part of the country?
Sure. So just like you said, state specific, I do live in Texas where we do have safe harbor. Safe harbor is a peer review process that was adopted by the Texas Board of Nursing. So if you feel like your assignment is unsafe, you can now, even verbally, they changed that within the last couple of years, file safe harbor. So you're saying, I'm going to take this assignment or I'm going to do this task, but it is unsafe. The chief nursing officer normally gets involved because it goes right on up to the top, and there's a peer review process that put into place. So if it does cross over to the Board of Nursing, the Board of Nursing will take that in consideration, that you did use this process. You still stood there and took care of the patients. You did file safe harbor. Now you're standing in front of us because there was a bad outcome or something happened, and we're going to take this into consideration. So that's only true in Texas and in New Mexico, in my understanding. And then interesting, you and I had this conversation because I think that your experience is just amazing, that talking about ADO, because nurses will ask me, okay, so I want to refuse an unsafe assignment and I'm at a union hospital, so I'm going to file ADO. Will that cover me for the Board of Nursing? So I want you to talk about that a little bit, because I had to ask you about that, because I told nurses not in the state of Texas, you have to file both of those. You cannot just do one. So talk about ADO, and then I'll tie up the rest of that question.
Yeah. So the ADO is called the assignment despite objection. It was started by an SEIU nurse, Glenda Canfield, in Sonoma County, north of San Francisco. She was an OR nurse, and decided in her hospital, which was union, to start understanding and using state regulations to leverage the nurses and to make change.
Yeah.
So it's important to understand where the ADO comes from, and that it was based on California licensing laws for facilities for hospitals, which is Title 22. It wasn't based on the Nurse Practice Act, because, again, what's a Nurse Practice Act do? That protects the public. So who's out there talking to the hospital, making the hospital responsible for creating an unsafe assignment, when I have my own license that's regulated to protect the public, but I'm not making that decision about the staffing, right? So Glenda, came up with this form, which basically was a way to document in paper back in the day, right? It's like 25 years ago, I think, so, or at least. And then the form was signed by everybody. So she was a very good organizer. So the idea was, you filled out this form, you said, here's the staffing situation. We have this many patients, this many CNAs, this many nurses. You give a breakdown and the time, the shift, who's charge nurse, who's the manager, who's the nurse manager on call, or a house supervisor. And then you'd have everybody sign it and agree. And so basically it's a witnessing. So it's very different than ones that are used online now. Because the whole idea was like, hey, I'm going to put my name on this and I'm going to do this with my coworkers. That's a very powerful statement to make. And then what it would basically do was, then you give a copy to the house supervisor, the nurse manager. You say, here, I'm serving you. So it's basically like you're serving them with proof that you're serving them with basically an informal affidavit of a dangerous staffing situation that now is signed by everybody, right? Or the majority of the unit, or it could just be 3 people if it's a small department, right? It could be cath lab recovery. There's 2 nurses, right? So they can do an ADO. So any kind of setting, it doesn't really matter. Then now there's this awkward situation where now the nurse manager's got this piece of paper and they don't know what to do with it. They're like, when we first started using these nurses, they were like, no, I'm not taking this, take this back. I don't want this. No. And it's like, no, you're going to take it, because we're letting you know, because for folks who don't understand, who aren't in nursing, for the public watching this, is that there's a hierarchy in a hospital. And so nurses are nurse managers of nursing departments, and often other departments. And then there's usually a chief nursing officer or vice president of nursing. So there's like a top level nurse. That person has a license too. So it's also a way to make them liable. But again, it's based on the state licensing laws for California for facilities, so that this is a way when something happens now we can go to the state, nurses could go to the state and their unions and say, hey, this hospital is egregiously, like on these 20 days, we have forms for, 60 days straight in this unit, or widespread, or during this period, or some situation. And then there's proof that you have, that you can show legislators, that you can show to the state licensing board, you can submit them to Joint Commission. Now, about the nurse board, yeah, they don't care, right? I mean, they may care that it's documented, but again, it also doesn't mean you get to refuse. It means you are going to take your assignment despite objection. So assignment despite objection. That means you are going to accept the assignment despite objection, but you are saying, here, I am letting you know and informing you, hospital or nurse manager, this is unsafe. So I hope that makes sense, because people have the totally wrong idea about it over time, because it's kind of taken on its own life through different unions trying to like own it, or, there's a specific reason. And when you pull up a lot of those and you bring those to like a state legislator, right, or even a local legislator, that's going to be very powerful, because people are not going to sit around and call nurses liars. They're just
Correct. No, and so I think that that's a good point. So using that tool, if you are in a union facility, because you do, part of it is just playing the game. And just like you said, pivoting off what you're saying is that you're accepting despite objection. And like I tell nurses, you're not coming in, you're not giving all these ultimatums. You're coming in a respectful manner and just saying, I'm sorry. So you're asking me to violate 217, 1A, S, and T. That's for me in Texas. S is you making the unsafe assignment. T is me accepting that unsafe assignment. So I do sling around that one. And most, even leaders, just like you said, they're not educated. They have no idea. So empowering yourself and understanding your Nurse Practice Act, your rules, your regulations. If you don't have a formal Nurse Practice Act, you do have rules and regulations. Mm-hmm. And pivoting off of that, and even using some civil law. At the last Nurses Association meeting, I asked the lawyer for the Texas Nurses Association during one of the meetings, hey, so I know we were talking about staffing, so I want you to riddle me this. So if a nurse in the ICU, let's just use that, for example, takes on an unsafe assignment, she takes on 2 instead of 3, is that the definition of medical malpractice? I already knew the answer. I wanted him to tell the nurses, yes. Gasps in the audience. I said, please, sir, will you repeat that? If a nurse knowingly and willingly takes on an unsafe assignment in any setting, is that the definition of medical malpractice? Yes. So using that as well. So you asking me to violate civil law and, practice medical malpractice, because this could be considered negligence if I take on this assignment. Because I've seen it on the civil side. I've been an expert.
And you're saying to have those conversations with the manager right there, know the law, even if you've got to carry it on a card, you've got to pull it up in your notes on your phone. There's really no reason for people not to have those resources with them. Pull it up and you've got to flex. Look, we are emboldened as RNs, right? We are empowered to make judgment calls, independent judgment calls and assessment, right? Yet when we do that to our employers, we get gaslit, we get questioned, we get ridiculed, we get bullied. Right. So they want us for one thing that they need us for legally. Right. But then they don't want us to really use our brains when it comes down to actually protecting patients and protecting our license. So it's very important that the public watching this and folks that aren't in healthcare, that you understand, like, when we can all work together, right, this is where we're going to make change. That's why we always ask the public, get behind reform, get behind whistleblower protection laws, get behind worker laws, worker protection laws, get behind safe patient ratio laws in your state. Help nurses pass safe patient ratios. We need this in every state. We need to also have safety legal language about violence against healthcare workers, right? These are because again, if healthcare workers aren't safe, you're not safe either. Newsflash. All right. That's my little,
Well, and then just finishing that up, just like you said, knowing your rules and regulations, using those in a respectful manner, and then just paying attention. If you look at the schedule and it's 30 days out and there's 3 people on the schedule, there should be 9. Why are you waiting to the day you show up? Stop. Address have those conversations early on. Don't wait to the last minute. Sure, 5 people could have called in sick, but why are you not having those conversations in a respectful manner early?
What's the contingency plan, right? And this is important, is that a lot of times managers will do this really insidious thing where they won't want to email you. Just let's have a conversation, right? So this is very important that you memorialize those conversations into an email, and try and have the conversation with another person there on your side, a friendly, as we call them, a buddy, somebody who feels strongly about this, so that you can then CC them also on the email to the manager. Thank you for your time. According to the conversation we had, this is what we talked about. I wanted to just summarize it. I expressed my concern that on January, June 15th to the 20th, or the July schedule, we are 3 people short every single day. And there are, and then the skill mix, because if you're a good nurse, you're going to also be paying attention to the skill mix. You're not just going to be a robot coming to work, but this is what they want. This is why they put the schedules online. It's all secretive. You can't see this certain schedules. It's important that we know our colleagues and we know the skill mix, and especially when you work on a mixed floor. I work telemetry, step down, open hearts, vents, renal patients. I mean, we did everything pretty much. So again, memorialize those. So next topic, always write that email. This is kind of goes right into it. We're going to talk about, how do I protect my job and license as a nurse, right? So then what do I do? I'm stuck. The hospital, I'm not in California with ratios, but even so, they can still fire you, right? So what do? How do you protect your job and your license as a nurse, Maggie? What do you say to nurses?
Know the Nurse Practice Act, know your rules, know your regulations, have these conversations up front, stand united. That's repeatedly what you and I have both talked about. You have to stand united with your people. You all know it's unsafe. Everyone has to speak up. And then not like that, if they're not respecting you, why are you still there? Why are you still there? You're a nurse. Do you know what? You can have a job 5 minutes from now. Don't kid yourself and don't undervalue yourself. If they're not willing to invest in you, why are you investing in them? Leave. Now, that's easy for me to say. You're in a rural community. There's one hospital. There's one clinic. Sure, that's easy for me to make that statement. But as Lori Brown, RN JD, talks about in her book, she defends nurses in front of the board. It's not normally, if you're experienced this, you're more likely to stand in front of one of these boards or litigation. So why are you still standing there? You don't want to be standing in front of the board of nursing if they're not respecting you. You know it's unsafe. Statistically speaking, what do you think your likelihood is that you're going to be involved in litigation if they're doing unsafe stuff? Do that math yourself. And then you need to figure out what's safe for you, safe for the patients, and that you're advocating for your license and for the patients.
Absolutely. Yeah, I would agree. And it's really tough. I mean, I'm no longer in California. I don't have ratios anymore. I want to, I think, I really miss the clinical aspect of nursing. You have to pick and choose. You got to decide. It just means going out there and trying it. You may, and when you're a new grad, I get it for new grads. There's so much pressure to get a job and that job be the everything be all. It's okay if it doesn't work out. Yes. The marketing is really powerful. Do not believe all the marketing that a hospital lays out to its staff. It's not that different from hospital to hospital or skilled nursing facility to skilled nursing facility. It does, it doesn't matter what the hype is. You may find the best, places like a really local community hospital. That's where I worked. It's 225 beds. So find what works for you, but do not hesitate. Don't hesitate to make change. And if you, and maybe you have to move, maybe you have to change up a situation.
Or maybe it's just a different unit. I've heard a nurse say that I just switched unit and it was like night and day. The staff is supportive. I was like, and there you go. So even just looking outside your own unit, maybe it's like you don't fit there, or maybe you're not comfortable there. It is okay to leave that unit. Go somewhere else, try something new. Who cares?
Definitely always be the answer to your own, problem. Yes. Be your own solution first. Do everything you can and be positive. And, because oftentimes when we are really not in a good situation, or we don't really like the situation, or maybe we don't feel like we're part of the team, or it's not as welcoming as maybe we had wanted, we can kind of get into our heads a little bit and get negative outwardly. So it's really important. It could, like Maggie's saying, it could be just change department, move around first in your facility. Don't get like wedged in about making somebody else or wrong, or you don't like this manager, try to not get into that situation, because you're really going to have a hard time digging your way out and
Yeah.
staying in the same facility or company. Also, you can look into, work from home, home health,
Yeah.
community nursing. There's a lot to do out there, but keep yourself fresh, your brain fresh. That's the main thing. So that just leads. So that one was pretty easy. Anything else you want to add on that one?
No, I think that's perfect. Protect yourself. Again, you have the tools, just use those. Stand together.
All right. This is the good one here. This is a juicy
Ooh.
one. What does it mean to be deposed? I'm going to be deposed. Oh, freaking out. What is it, Maggie? What does it mean?
So this is one of the questions that I do get quite frequently, and this is exactly why I just wrote my book, Help, I'm a Nurse, and I'm being deposed. I'm going to plug myself here a little bit. It is on Amazon. It's $10. Really, it is worth the read. Stop it. Any nurse should have it. It doesn't necessarily, even if you're being deposed. So deposition is in civil litigation. So there's administrative, so board of nursing, civil, I'm going to sue you. And then there's criminal, which we all know about. So being deposed is normally it's the law firm that reaches out to the hospital or the organization, tells them that there's civil litigation and this is who's involved. Normally it's not the nurse per se. The nurse is just named in what is called a peer respondent. So your name was in the chart somewhere. You could have just done a blood sugar, but so you're in the body of it. So the case has been filed a petition. There is a civil suit. They have found your name in the chart. And so now they're asking what your side of the story is for this case, for this patient. So that's going to depend whether, like you did the blood sugar, that may be a 5-minute deposition. I walked in, scanned the patient's bracelet, verified, did what I needed to do and walked out. Okay, bye. I was the primary nurse. The patient died. I gave them the medication. Oh, that could be a 6-day deposition. They're going to want to know all the words. So this is oral testimony. There's no judge. There's no jury, but you're being asked questions by, it's normally the plaintiff's law firm, about what happened. The medical record, it starts with yourself. Tell me about you, Adrienne. How long you been a nurse? All your words, yada, yada. And then it gets to, tell me about, you giving this medication. Let's look at the medical record. What does that mean? And so I talk about this in the book because nurses don't understand what that means. And this is just a deposition. This isn't a trial. You should only be answering the question that has been asked to you. Example, where were you at 11:30 in the break room? What were you doing? Eating my lunch. Did you give a report? I did. Who did you give a report to? Don't offer anything. Yes, I was in the break room at 11:30. Yes, I gave a report to Adrienne. She was, no. Why are you, no, you were not asked that. No.
Now let me ask you this. So a lot of people, there's most likely you're going to be deposed if you were involved in care in a facility that is being sued.
Correct.
Usually that nurse is not the subject of a lawsuit directly,
Yes.
or is it more that they're just the side effect, right? So
we're not the deep pockets. We're not the deep pockets, honestly.
Right.
Why are they suing? For money. Something happened.
Money.
They want money. Who's the deep pocket? It's not the nurse.
So some nurses will still be employed. Others might be a traveler. I'd like to talk about that also. Travel nurses getting deposed, or they may no longer work for that organization. So do these companies help these nurses understand and prep for the deposition? How do they do that? Because again, it's the deposition that nurse is giving is going to affect whether a big payout happens, or could.
So this is all in my experience. I'm not a lawyer. I don't give legal advice. So most of the time, they're going after the physician and the facility, unless it was just like straight up gross negligence and it was only the nurse that was involved. It was the only nurse. It was the nurse, like say injecting air boluses arterially. That has nothing to do with the physician, right? That's solely just nursing conduct.
Gotcha.
But most of the time, they're not coming after us. So it's normally the physician and the facility, but you'll be asked questions. You'll be asked about what you did or did not do. The standard of care will be, on the big screen. And so I forget I feel like I got off the initial question here. Please.
I think it's that it's basically like what kind of assistance, like say I don't no longer work, but I want to say one before we say anything else, right? This podcast, this video, right, is for entertainment, it's for information purposes only. We're not lawyers. We're not giving legal advice. We're not advanced nurse practitioner. I'm not an advanced nurse practitioner. We're not giving any medical advice. We're just sharing our opinions and a conversation of our own experiences and answering some questions as we see it, how we see it. So like say I'm no longer working, and then is that company is their lawyer gonna reach out to me and say, hey, we're gonna help you get ready? Or am I just gonna go blind into a deposition? Or should I reach out to that company and say, hey, I've been reached out for a deposition, can you guys help me? Or do I reach out and say, I need my NSO, my nurse liability insurance? What do I do, Maggie?
Sure. So all of those actually. So you are no longer with the organization. In my experience, say it's a hospital. We're just going to use a hospital just to keep it simple. So the hospital gets this petition. And you don't work there anymore. You're a traveler. They normally are going to represent you because they have a vested interest to protect the facility. So they'll reach out to you, say, yep, there's a deposition. They're calling depositions. You're going to need to give your deposition in 2 weeks. Come on, we'll talk to you, whatever. That's when the nurse, if they don't understand their rights, is not able to advocate for themselves. If that doesn't work for you in 2 weeks, you know what you need to be saying? They're not running the show, you are. No, actually, I'm out of town. I'm not. That's not going to give me enough prep because I was the primary nurse on 5 different cases, and that medical record is 1,000 pages. 2 weeks is not going to give me enough time with my life and my family and my job to prep for this. So no. And then
are you saying, so really quick,
yes,
this is one thing, because I worked in informatics and I saw how it would be really easy to hide a lot of stuff in these little nooks and crannies in these EHRs, electronic health records. So, that's one thing that I always saw the nurses really being a disadvantage, or anybody who works at a facility, is how are you going to get access to those medical records again?
There it is.
You're not. It's not like a doctor who you can go to your notes and then go look in the EHR and not get dinged for it, right? If I don't work for the company, I mean, I certainly can't look at it whether I work or not work. Even if I have access, that's a HIPAA violation. So
no, you do have rights if you are being deposed. You can ask for the medical record. Now, most of the time in my experience, they're not going to send it to you, but they can send it to you redacted. So there will be information.
Okay, so this is important then. So what you're saying is that if you're being deposed, you can ask for the copy of the medical record, and you should do that in writing as soon as possible.
Yes, when I'm retained as an expert.
Can you refuse to be deposed? Can you say I don't want to be deposed?
No.
Is it contempt of court if it's civil? That's
a great question, and I will follow up on that. I don't know that, but so that other piece of that, I can quote you from the Board of Nursing. There is rules and regulation, and I'll just quote, talk from Texas. They do require us to comply with all investigations, cases. The Board of Nursing in most states does take a position that we have to comply with. So if they reach out to the Board of Nursing and say, hey, there's civil litigation that she's involved with and not complying, now I just involved the Board of Nursing in my case, and which you don't want. It may never go to the Board of Nursing. So just remember that piece. We are obligated to comply with cases.
Okay, so again, know your Nurse Practice Act. Know what your rights and responsibilities and duties are as an RN, LVN, whatever you do in healthcare, anything.
Yes. So you do get to look at the record just like I would if I was the expert. So it may be redacted. Who cares? You get a certain amount of time to look at that medical record before you sit down and you're asked questions. Mm-hmm. So then that attorney will normally sit down with you and go over, like what your role was. This is just in my experience where, let's look at your charting. Let's look at some of the stuff. Their best interest sometimes is not for you to be as educated because naivety as well can be part of, defense. But as the nurse, you better know what your role is, where you were in the chart, everything, because you will be asked to put up your right hand. This is legal. You are under oath.
And when you've been working under duress and under crazy assignments for weeks and months and years, and you've had an unsafe assignment, you're stretched so thin, maybe you're taking 8 patients and you should only have 4 or 6, or the patients are so sick. Let me tell you, there's very few patients you're going to remember, And there's hardly anybody you're going to remember the details of each day unless you're one of
you
those
need to say that. And you need to say that. You need to say
Right.
that. You need to say, I don't have independent recollection of this. I need to see the medical record. And then you need to follow up with, especially if it's a deviation of care that they're saying, and it's something you normally wouldn't do. Say in your normal practice, you would not have done that, but you didn't document it. You then need to say, but in my normal practice, this is what I would have done.
Right.
Now, the attorney will normally follow that up with saying, not done, right, nurse? And that does get slapped in your face. But then you can just say, your attorney then, if you go to trial, say, stop it. She's not perfect. Right. I mean, you can just say this was going on. This is when you pull in mitigating circumstances.
Here's another thing, when I precepted as a student nurse, I remember the gentleman I precepted with on nights. He handed me like this type piece of paper that had like an entire schedule of the night, like every single thing he was going to do, like his whole routine. And I realized later, and even now in this conversation, I've never met anybody. I have met other people, and usually they were male nurses who had this, a little bit of a guide, right? But I never met anybody who did one so detailed. Now, in retrospect, looking back, I think, wow, that's a very protective thing to do. That's a very proactive thing to do, to have, if you are one of these people that can stay on that schedule and you have a workplace that allows that. It was like the assessments, med time. So it was kind of the by when, what do you want to have done by 8 o'clock, by 9, by 10, by 12? So these benchmarks, but that's something to think about. Make yourself something like this that you are following, like for me, I always had all my charting and assessments done, like all that stuff by like 10:30. Like if I didn't have it done by 10:30 in the morning, I was freaking out. So I just like barreled through all that. And then I'd give baths or whatever. But, and also do nursing notes, because that way I know I can show right within 4 hours I have done my assessment. Now I'm going to just do nursing notes to add on to that, and the vitals and anything else that's impertinent for the patient. Charting is very important.
The expert has to look at all of that. I've been an expert on the civil side, and I don't care where you chart it. I've had to tell attorneys there is no case here. She charted in the flow sheet because that's why they called me the expert. So I don't care where you chart it. I said, nope, right here in the flow sheet it says. So chart it. Doesn't matter where. Drag that wheel on. What's the appropriate word? It's not cow. Wheel workstation on wheels around
the
with
wow.
you.
The wow.
I want to make sure I'm being politically correct here. And just again, if you can just drop some notes in. Scan the patient if you have that opportunity, because then you know that you have the right patient, and then just start again, even if it's just a note. Start giving yourself credit for what you did, because now it's on the big screen. You know what that looks like? Prudency. That looks like you're prudent.
Yes. And there's a lot of, there's another TikToker I know who does really great work and videos on notes, nursing notes. So, like find these creators. We'll be talking more about that. There's just plenty of information. So if you're not really paying attention to what you need to be doing defensively to protect yourself as a nurse, protect your patients, just get with the program. Just come subscribe here. Make sure you subscribe here. Subscribe to Maggie's YouTube, and follow her, both of us, on TikTok and Instagram. So let's talk about the patient side now.
Yes.
How does a patient know if they're getting proper care? How do you even know, right? I mean, we've had patients that have come to us, all of us have, and kind of whispered about, well, this happened. Was that weird? That was kind of weird. Or I didn't really like that nurse, or this person was a little rough, or whatever it may be, the bedside manner of somebody they didn't really care for. And then there's other times where you see a patient and you're like, wow, there's been some major errors here. There's been some, so again, this is a difficult question. We're not going to be able to even answer this question in totality, but it is important to know that when nurses are treated well, when healthcare workers are treated well, when they're paid well, when they're respected, when they're staffed appropriately, when there's good morale, right? Patients, like, we are the eyes and ears as nurses. So a respiratory therapist, a radiology tech, a CNA, a dietary worker, a housekeeper, right? All of these people have reported things and saved patient lives that when I have been working, the phlebotomists, I mean, the transporters, the
Yep.
volunteers, right? So when your hospital workers are safe and they're being taken care of, they're in a better position to be your advocate and really be the voice for you. But, when you feel like if many hospitals have, a system where patients can speak up, at our hospital, they could just do their own rapid response. Um, so it's important if you feel like something's wrong to speak up and
Yes.
and go up the chain of command. So one thing that I want to talk about, and Maggie can add into, there's a chain of command in every hospital. A lot of patients don't realize that. They just start bitching to everybody, complaining to anybody who will listen because they're having the worst day of their life, or they're frustrated, or they're with their family member who's having the worst day of their life, or it's a crisis, or they're trying to get information about somebody. All these different factors. A lot of stress going on. And it's important to know, look, if I'm a patient, I've got an issue going on, I have a real concern, ask the charge nurse. You go to the nurse, the primary nurse, right? Talk to them, say, I have this concern. Be nice, be calm.
Yeah. 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 Yeah.
Count backwards, 5, 4, 3, 2, 1, right? Say, I have this concern. Can you help me address this concern? If you're not happy with their response, then you can ask for the charge nurse. If it's during daytime hours, Monday through Friday, there's a manager. There might be a manager 24/7 in an ER. It just depends. And then there's a house supervisor, and that person is there nighttime, 24/7, and that's who you can talk to. So follow the chain of command. What do you think, Maggie?
No, I agree. And when I was doing patient advocacy, that's exactly what I would tell patients. No, I no longer do that anymore, but that's number one. I was like, don't try to, you're not going all the way to the chief. There's most of the times there's a patient advocate within the hospital, which again, I tell patients they're not going to do anything for you. They work for the hospital, but you need to say that you called them. You have to play their game, right? That's not who you're actually hiring, right? That's why you brought me along, but we have to play the game. So you start there because they have a vested interest in the facility, and then you use the charge nurse, the manager, and then it goes up to the chief nursing officer, the chief medical officer, until you get someone to hear your voice. Absolutely.
And it's important to, also as the public, don't buy into the marketing of the hospital, right?
Mm-hmm.
It's like, again, they're going to show you rainbows and roses and, there's a spa inside the
You
hospital,
already know
right?
this isn't true. Turn on the news. You already know it's not true. We're not telling you any
It's a
lies
lie.
here.
It's all a lie. Hospital marketing is a lie. Healthcare marketing is a lie. Do not believe it. Yeah. So this is why it's really important, right, to have, safe patient ratios, nurse to patient ratios, and also a safe environment of care. So these are terms that we would use in a more regulatory setting, the safe environment of care, the environment of care. We say that a lot in nursing health, whether it's a surgery center, skilled nursing facility, a doctor's office, a clinic setting, it could be a dialysis center, whatever that environment care is, you deserve to be safe. And let me just tell you,
Yes.
if the workers are not safe and they are finding weapons or being approached with weapons or danger or violence, that could easily go right to you in that room, wherever you are, the hallway, anywhere you are at. So this is so important that the public understand that we have to be safe as healthcare workers. What are your thoughts on that, Maggie?
Yeah, so that Dallas nurse that got shot in the face and then that social worker that got shot, that's exactly what I was screaming to that representative about. The only reason why there was a police officer in that building actually was because of Representative West. So he was able to respond quickly because he was in the building. But like I tell people, this was on the labor and delivery unit with moms and babies in a lockdown unit. Why isn't there like a metal detector? If the Dallas Stadium has a metal detector, why doesn't the Dallas hospital have a metal detector? This person was in and out of the building, had an ankle bracelet on. We have patients in the ICU strapped to beds that are intubated and sedated. How are we protecting them? Right? So patient advocacy is also nursing advocacy, because if nurses aren't safe, neither are patients. And if we're outside of the building screaming, asking for our protection, we're trying to protect you. You need to be standing next to us, because if we're not safe, you're not safe.
Yeah, 100%. 100%. And I've had patients come out in the hallway. I mean, I have had a couple instances where I felt unsafe. And, one was a patient who was at the end of a hallway adjacent to a stairwell. And, we had no way to stop people coming up and down the stairs. A lot of people would use our floor as a shortcut.
Holy cow.
Because it went over to the doctor's offices. So a lot of times doctors, other staff, because it had a walkway that went to another building that was all the doctor's offices. And if they didn't want to go on the first floor and be seen, they would go across on the second floor. And, so we were like, there's no way to, like, we have 2 security, right? A square mile campus, right? Huge campus. And there's just no way to secure this kind of environment. And I remember and so we just started shutting the doors. Like, what was that going to do? And I remember a woman came out. She was one of the more ambulatory patients I ever had, and said, do you want me to call the police? And I was like, I don't know. Like, you know what I mean? But the answer should have been yes. I think that, we tried to de-escalate, but I learned very quickly. I didn't really have a big conversation about calling the police, but I do want to say to healthcare workers, anybody watching this, call the police. Do not rely on hospital security. Call the police. Don't allow your job to be threatened. They used to threaten nurses and healthcare workers if they called the police. If I'm being assaulted, I have the right to call the police. If somebody walks in and, like, slaps you and you work at Walmart, you're going to call the police. There's no such thing as needing to put up with violence or a requirement to put up with violence on a job, and especially in a healthcare environment. So, if you're a patient, you see violence happening, or you see somebody starting to escalate, pay attention, especially when you're in the ER. ERs are very dangerous places in general. Be aware of your environment as a worker, an employee, as a patient, where you're parking, where you're walking in. And support safe ratios. So, I don't know what else you want to talk about. We're at like almost an hour here. This is pretty.
Yeah.
It's pretty
So
fun.
the other thing that I wanted to ask, actually, since you're talking about that, is that Texas passed a bill for violence against staff. And so I just was at this meeting on Friday that we talked about. Can you hear me okay? I think I lost you.